This is a 71-year-old male. He was presented at emergency department because of he was suffered from repeated chest distress for 5 years and aggravated for half a month. And he has hypertension for almost 10 years and elevated fasting glucose for 10 days. And he has already received the CRTD implantation for 2 years. And he has a history of smoking and alcohol drinking for almost 30 years. And the physical examination on admission revealed that there was few most cereals in the lungs and cardiac enlargement and moderate edema in lower limbs. The laboratory examination after admission shows that the patient has renal dysfunction and his eGFR is only 32 milliliter per minute, and his BNP is remarkably elevated. The ECG and Holter show that the patient is a sinus arrhythmia, and the Holter discovered that he has the ventricular perimeter contraction and ventricular tachycardia. The CAG coronary artery gradient for this patient reveals that the patient's coronary artery is normal. There is no atherosclerotic lesion or stenosis or congenital anomalies. This is RHC waveforms for this patient. The furthermore, right heart catheterization results finds that actually the patient is CPCPH with elevated PA pressure is about 44 millimeter of mercury, and the PAWP is also elevated. The PVR is almost 6 Wods. After the heart team consultation, the final diagnosis for this patient is dilated cardiomyopathy and heart failure and NYHA class 4 heart rate, and with pulmonary hypertension, CPCPH, and hypertension, and coronary kidney disease. This is the imaginations of echocardiography of this patient. From the transthoracic lung axis view, we actually can see the dilated LA and LV, and LV is the systolic function is decreased, and there is also mild to moderate pericardial effusion. And there is a mitral regurgitation, at least moderate, and mild to moderate aortic regurgitation. And this is a peristernal thorax view of the left ventricle. From these views, we can see the global reduced movement of the airway. And this is the apical four-chamber view. And from these views, we can see the both right and the left chambers dilated. Above of all, we give the final diagnosis. The patient is dilated cardiomyopathy and dilated left and right side chamber.
So first of all, I introduce my whole team, Dr. Zhang Hang, Dr. Xie Dujiang, Dr. Yu. They're working very hard to measure the pulmonary arterial pressure, PCWP, as well as CO. Because of the extremely large right atrium, so it will be very difficult to advance the Swan-Ganz catheter into the pulmonary artery. After almost 10 minutes attempt, and still they failed to advance the Swan-Ganz catheter 2. So instead, they used the long sheath with the outer diameter of 8.5 French to put at the distal pulmonary main trunk. So I think now you can see the angiography for pulmonary using the large long sheath. So the sheath tip is just above the level of pulmonary valve, directly forward to the ostium of left branch. So usually we need to use two projections. One is the epicranial, the remaining one is the cranial. Both are very shallow projection. That means only 20 degree for cranial, also 20 degree for LLO. After pulmonary artery denervation, I think these are very important injection to confirm the bifurcation area between left and right branch, and it will be very useful to guide the ablation site. So usually, according to our animal study and autopsy, so usually the main trunk of pulmonary artery sympathetics localized at the left lateral wall is a neural nose hub on the left lateral wall of main trunk of pulmonary artery, and the nervous trunk will bifurcate just at the distal bifurcation level, with one around the anterior to posterior wall of left branch, and another one localized at the posterior wall of right branch. Right now we can see when we have finished the angiography for pulmonary artery, so it's very clearly to say the Svanger's cancer is just in the main trunk of pulmonary artery, right? So, camera, can you see the pressure line? If you can see, so now how much is the systolic pressure is above the 70. The diastolic pressure is around 30 to 35, with a mean pressure of 47. So it's a very significant increase to the pulmonary arterial pressure. Once we have finished the measurement of the pulmonary arterial pressure, so I think it will be a little bit difficult. Basically we tried to use this Svanger's case to engage the distal pulmonary artery, but because the right atrium is pretty big, so it's very, very difficult to get the Svanger's case in. So instead, we use the pigtail to put in the left ventricle to measure the left ventricle. So now we have finished the measurement of the hemodynamic. Mean pulmonary arterial pressure is 47. PCWP is 23. So the difference between mean pulmonary arterial pressure and the PCWP is 24. Cardiac after pause, how much?
4.3.
4.3. So the PVR should be greater than 5. How much is the PVR? 6.28, correct. 6.28, okay. So it's a typically a combined pre and post capillary pulmonary hypertension secondary to heart failure because of the significant reduction in left ventricle ejection fraction. So the final diagnosis is a HIF-RAF, heart failure with reduced left ventricle ejection fraction. So now from the main screen you can see because the lung sheath with a 8.5 French of the diameter. So the next step is we will use a piercing catheter to directly to perform pulmonary denervation. So how big is the pulmonary artery diameter?
32.
32.
Yeah.
So usually we will define the diameter ratio of piercing catheter to the main trunk of pulmonary artery at 1.1 to 1.221. So the optimal diameter of piercing catheter will be 35 millimeters. So this is a piercing catheter with 10 electrodes pre-mounted on the distal circular ring. So now you can see the angiography. So I have put the catheter into the lung sheath. So I think now you can see the distribution of 10 electrodes And also, once the electrodes were released from lung sheath, simultaneously I need to slightly pull back the lung sheath and to push the piercing catheter out of the lung sheath. So right now you can see the distal circular ring of piercing catheter just localized at the orifice of the right branch. So simultaneously, I need to slightly clockwise rotate the catheter. So because of the very limited space to rotate the catheter, so I need to keep withdrawing the lung sheath and rotate. Can show me the geography from epicranial. Okay, this is epicranial. So it should be as a 1, 2, 3. So I think the upper edge of the third ribble will be the good position to define the ablation site. So right now, I tried to get more resistance, more intention for the distal segment of the catheter. So I think number 2. So from the camera image, I think you can see the main screen of the generator. It just start from 0 temperature and with the gradual reduction of impedance. So right now, the temperature is increasing not slowly. The target optimal temperature for ablation is 50 degrees. So now it's close to 47, 49. 问问病人有没有胸痛？没有。Okay. So also generate has a automatic function to terminate the ablation once the temperature is greater than 50 degrees. So now the effective ablation time is 75 seconds. So how to define the effective time for ablation, Dr. Zhang Hang?
150 seconds.
So usually we calculate the effective ablation time from the timing point when the local temperature is greater than 50. So usually the machine will need at least 20 seconds to achieve the local temperature greater than 50 degrees. So I think it's fine. Right now it's 112, right? So we have finished the first round of ablation by the second electrode. So right now is the second round of ablation using number 3 electrode. So from the image you can see number 2, number 3 are two very, very good electrodes to match the golden ablation site A and C. So even the launches is pretty large with the lumen, but because the piercing case is almost 7.5 French, so it means that there is a very small space to measure pressure from launches, but we can try because before the procedure, so the mean pulmonary arterial pressure was 47. Okay, so let's see how much change of mean pulmonary arterial pressure. So right now the mean pressure is 39, 38 to 39. It looks good. Looks good. How much is the temperature? Even 52.
Yes.
Why? Because they designed the upper limit of temperature is 50. So once the temperature is greater than 50, so the machine will automatically terminate the ablation. So the procedure is very safe because the patient has the combined pre and post capillary pulmonary hypertension. So once we get a slight reduction of pulmonary arterial pressure, I think there will be slight rebound, increase of the PCWP, or even, okay, finish it, right? Okay. So we have finished the ablation at site A and site B. Now I think we need to slightly rotate the catheter to get the ablation at the site C. So from the pressure line, we have finished the four rounds of ablation. So right now, systolic pressure decreased to 60, I think less than 70. So after finish the ablation, so from the image you can see, I very gently, very carefully remove the electro catheter, PAD catheter into the lung sheath. So the remaining step will be very, very simple. So because we can finish the ablation at 3 sites. So now Dr. Xie will remove the lung sheath from PA. PAD is an emerging new technique for treatment of pulmonary hypertension. According to the WHO classification, there are 5 types of pulmonary hypertension. Group 1 is a pulmonary arterial hypertension. Group 2 is hypertension secondary from heart failure. Group 3 is associated with a lung disease, particularly interstitial lung disease or even COPD. Number 4 is a PH secondary from CTEPH. Number 5 is a group without very clear etiology of the pulmonary hypertension. Okay. So still the reduction in systolic pressure is about 20 mmHg. Okay, I see. So
Wait minutes.
so right now we still need to wait. So far, there are 3 recordings of cardiac output varied from 2.7, around 2.7. I think post the procedure, the reduction of PA pressure is much more important than change of CO, because the patient has very higher PVR before the procedure. I don't think we can get much more reduction of PVR immediately after the procedure. But the dynamic monitoring is very important. So how much right now still?
2.8.
2.8. Good. So guys online, I think we have finished the whole procedure of pulmonary arterial denervation. For this case, with the combined pre and post capillary pulmonary hypertension, we showed the standard procedure, standard steps of the how to do the PADM. The procedure is very easy because once we have finished all the angiography, measurement of hemodynamics, we only need to take 10 to 12 minutes to finish the ablation at the four sites.
Still 3.1.
Okay.
3.5. Increase.
So probably I
slowly.
think we need to wait long time to get the recovery to make the patient recovered from the ablation. Right now, cardiac output increased to 3.5. Sometimes the measurement of CO is not easy. It usually takes a long time. So from our side, usually we need to get the mean value of CO from at least 5 to 10 measurements. Right now is 3.5. Also because the swan cancer was kept in the blood system for a long time, so it was getting softer and softer. That's another problem to accurately measure the hemodynamics. Good.